right, so we'll get started. It is 8:30. We'll do a call to order. There's an official notice of the publication in the Daily Record and a copy of the Open Meetings Act located on the north wall over here. So we'll go into roll call.
Wade,
Here.
Festerson,
Here.
McNally, Rogers, Weiss, Jones, Wilkin, King, Espinoza.
All right, so we'll do and get a motion to approve the minutes for last month's meeting.
So moved.
Second?
Wilkin,
Yes.
Wade,
Yes.
Weiss,
Yes.
Espinoza, Festerson.
Yes.
All right. So we have do the approval of the action items. Can I get a motion to do them as a group, A through S this month?
There's a lot of them.
Motion to approve A through S, Festerson.
Second.
And roll call?
Okay. Festerson,
Yes.
Wilkin,
Yes.
Espinoza,
Yes.
Weiss,
Yes.
Wade.
Yes. All right, a couple presentations this month. First off, Molly Elston. Good morning.
Good morning. Okay, let's get you shared. Share. And. Okay, share. And minimize. And then. There we go. And off you go. There we go. Notes. Is there a way to get it to see the notes? You know what I mean? Like the presenter view. I do not know how to do that. I'll be okay without it. Okay. Yeah, that's fine.
Okay. So I'm Molly Elston. I supervise our STI clinic and our immunization clinic. I am very excited to be here today to talk to you about all the good things going on in clinic and to highlight our staff's work. So I will jump in. Just a quick overview of our clinic and what we do. So we have 10 full-time staff currently. We have 3 clinic clerks. We have 1 medical assistant. We have 3 public health nurses, 2 nurse practitioners, and then a clinic coordinator. Our services are located in the Midtown building. So STI clinic, we serve anyone 13 and up who needs testing and treatment. We're open Monday through Saturday with evening and weekend hours. And then we do walk-in appointments on Wednesdays, otherwise by appointment on the other days, or walk-in visits on Wednesdays and by appointment the other days. And then we also have express tests available walk-in every day. And then our immunization clinic, which is in the same space, same staff. Anyone can access this clinic who is eligible for VFC and VFA programs, and I'll highlight the eligibility criteria for those. We do our VFC clinic on Tuesday mornings, and then we do VFA clinic by appointment Monday through Saturday. And then on Fridays during fall, flu, and COVID season, we do walk-in COVID and flu vaccines. So a little bit about immunization clinic and what's going on. So I'll highlight first our VFC and our VFA criteria. So VFC is Vaccines for Children. It's a federal program that provides free vaccines. So the criteria is that the child has to be under 19 and meet at least one of these items. So either uninsured, so no insurance whatsoever, underinsured, meaning they have insurance, but their insurance doesn't cover the full cost of the vaccines. They could be Medicaid eligible or American Indian or Alaskan Native. So that's the Vaccines for Children program. That program is very well funded. We're able to get the vaccines we need to meet demand for our clients. And that continues to be the case. So we're lucky that that's the case. The VFA program, Vaccines for Adults, That is another federal program that's a partnership with the federal government and the state. That program is for adults 19 years and older. That is only for adults who do not have any insurance. That program is underfunded and has been for the last few years, so we have struggled to get the vaccines we need to meet demand, and unfortunately, we get far less than what we need to meet the demand for uninsured adults. And that's just uninsured adults. That's not considering the underinsured adults we're not able to support. So that program, I'll talk a little bit more about later, is underfunded, and so we have to have a wait list and limit appointments based on how much vaccine we're able to get allocated to us by the federal government. For both of these programs, there's no residency requirement and there's no proof required for the criteria above. So a little bit about our impact in 2025. So this chart highlights how many immunizations we administered in 2024, that's the blue bar, how many immunizations we administered in 2025 so far, so through October 14th, yesterday, and then how many we should be at to meet our 2024 totals, that's the gray bar. So you can see that the VFC program, we're on track pretty well we're just about at the expected amount for where we're at in the year. We've got 2 months left, so that's good. The VFA program, we're below what we should be hitting based on last year's totals, and I'll talk a little bit about that. And then our total as it relates to the VFA program impacting this total, that is also a little bit under what's expected. So as I talked about, the VFA program's not able to meet demand, and in fact this year we ran through our allocations from the state in April as a state. And so from April to July, we could not administer. Pretty much effectively, our VFA program was shut down. So that is a problem in terms of access and impacts our ability to serve the community. Our immunization clinic demographic, so this is for all of our immunization clients, both kids and adults. So 50% of our clients in 2025 thus far are Hispanic, 23% white, 14% Asian, and 11% Black. We do see quite a high number of immigrant and refugee individuals who are seeking residency, paperwork, and that sort of thing. And there are requirements for that, obviously, for them to get immunization. So we help with getting that taken care of for them. So in terms of what we're seeing at a county level, so I highlighted what our numbers were in terms of how many vaccines we administered in our clinic. What we know at a county level, the best data we really have is from school data. So I wanted to show these two charts to show what's a national trend, and that's exemptions. I'm highlighting just measles, mumps, rubella, the MMR vaccine right now. So the goal, I guess that's the next slide, but in this slide, if you look at the orange line, you can see that there's a gradual uptick in MMR religious exemptions, both for kindergartners and for 7th grade. And so religious exemptions is kind of a catch-all, so it doesn't always have anything to do with religion. It just has a little bit broader ability to access that exemption. So we're seeing increases in exemptions for 7th graders and kindergartners in Douglas County not getting vaccines. This shows how many completed doses, or the percentage of completed doses for kindergartners, that's the blue line, and then for 7th graders, that's the orange line. This data is from DHHS Nebraska, and it's collected from schools through surveys, so I don't know what happened in 2015 to 2016, so I kind of ignore that. The trend is that vaccine doses overall are slowly trending down in terms of percent completed in those grades for both grades. The goal for kindergartners is to have 95% or higher coverage, and we are getting close to straddling that line. If you look at the lower line, we're still above it for Douglas County, but the trend is trending down. Some quick updates. We do have VFC and VFA COVID and flu vaccines that we've received. We also got supplemental funding through our VFC grant recently, so we'll be able to do pop-up clinics again this year. So I'm hoping our total administered will increase a little bit more. We talked about the VFA funding challenges. We've had a lot of community confusion related to vaccines and what's recommended and who to trust. We've had just clinical confusion as clinicians and not being able to get the guidance we need from sources we previously were able to get it. So those are some of the things for immunizations that we're confronting as a clinic. I won't go through this ACIP information, but I included it in my slide in case you want updates on what happened during that meeting. Suffice to say, there were some minor changes on the MMR vaccine that won't really impact our work. There may be future discussions on universal vaccination for Hep B. The COVID vaccine, the Advisory Committee on Immunization Practices recommended shared clinical decision-making for everyone. We do shared clinical decision-making every day for other vaccines, so it's not a change to our workflow. It just means that there wasn't a strong recommendation from the federal government for COVID vaccines. We created our own recommendations. Essentially, we recommend that all 18 and up get the vaccine, all pregnant, postpartum, and planning to get the vaccine, all 6 months to 2 years old get the vaccine, all 2 to 17-year-olds with risk conditions get it, and then 2 to 17-year-olds without risk conditions can discuss it, and they may get it if that is right for them. And then we want anyone who's not been previously vaccinated to get it. And we put together these recommendations using a variety of professional organization sources, CDC recommendations, et cetera. We talked about this, so I'll skip past this in the interest of time. Goals for this year, we did about 36 pop-up clinics last year. We're getting a late start this year due to some federal slowdowns, so we'd like to do 30 this year. Maintain or increase the number of VFC vaccines administered, the number of VFA vaccines administered, and then we'd like to work on achieving better access to immunization data. All right, I'll breeze through the STI clinic updates because I've taken a lot of time talking about immunizations. There's a lot going on with immunizations right now, as you all are aware of, I'm sure. Quick information about our impact for our STI clinic. We're doing about 320 visits a month in 2025. Majority of our clients see a provider for a full visit. You can see that's the kind of orange bar at the bottom, which is a bit larger. The green bar is our express visits. And our highest volume month was July 2025. A little bit about our clinic demographics. Majority are age 20 to 29, 47% white, 29% black, 19% Hispanic. We have had some really good collaborations with the STI control and health promotion groups to meet clients where they're at. So for example, we often will have clients with congenital syphilis, for example, who we need to ensure they get 3 doses or they have to restart. And did I say congenital syphilis? Pregnant clients with syphilis, and we don't want a congenital syphilis case. We want to avoid that. So we really need to ensure that they get treated appropriately. So that often means working with our community health workers, working with our STI control group to find that client, to get them treatment, to get them other resources to retain them in care. So that's been a really big success. There's a bicillin shortage going on right now that kind of puts a challenge to our work to treat syphilis. So right now we're only able to treat clients who are pregnant or who have a high barrier to completing bicillin, which is the preferred treatment. Other clients get doxycycline. Last big thing I want to highlight is that we started PrEP at our health department. So we have not done PrEP previously. HIV PrEP, it's pre-exposure prophylaxis. So it's a pill. We offer daily PrEP. So it's a pill that clients take every day to prevent HIV acquisition. Super powerful medication. Up to 99% effectiveness if it's taken regularly, even down to like 4 days a week, it's still effective. So incredibly powerful tool. We originally thought we were just going to do samples and then refer out, but through a partnership with the state and through Gilead, who's offering us free samples, we were able to actually start giving the samples and then doing the labs in-house and actually treating or prescribing and maintaining clients in-house. So that's super exciting. We started with an initial population of men who have sex with men and transgender women because that is who the sample pack is indicated for. We'd like to eventually roll out further to all clients when we can. Hopefully we can get some staffing in place to allow for that. So that is super exciting. I I won't go through this whole list of milestones, but suffice to say that we have, since July 8th, when we launched this pilot, we've put 25 clients on PrEP, which is huge and super exciting. We didn't realize we'd get that much uptake. So super, super exciting for our clinic to be able to offer that to our clients. I won't go too much through these in the interest of time. Quick overview, our goal is for the year is to increase the number of STI clinic visits by 10%, and then to hopefully get staffing and funding to expand our PrEP program and hours for a couple of days where we don't do the full 12. Last thing, we are moving towards considering billing so that we can capture costs for clients that do have insurance to create more financial stability. So our clinic coordinator, Kelly, who was promoted from a public health nurse position, is working on that. That will allow us to have some independent financial stability for our clinic in case we have cuts, in case things unexpected happen. So that is something we're working on. We would still be offering free services, but this would be for clients who have insurance and would be willing to let us bill it, that we're, kind of leaving that money on the table currently. We've got a few new staff. We've got a new public health nurse, Jess Scott. We've got a clinic clerk, Maddie Rogers. And then one of our public health nurses was promoted to clinic coordinator to help with our electronic health record and with billing. So we did just get our Nebraska Medicaid provider application approved, so that's super exciting. So our goal is to start billing insurance by end of year next year. Yeah, so that is what I have for you. Thank you for your time. Any questions?
When you mentioned the VFA individuals that you didn't have vaccine for last April, were you able to recruit them someplace else?
Yes, we have a list of community-based organizations and FQHCs and lower cost clinics that we give to folks if we're not able to help them. We also let them know that they can try calling back when we kind of know when the funding is going to roll in next. So we'll sometimes tell them if you can't find it, try calling back. So we give them kind of a package of options. Yeah.
Thank you, and thanks for that presentation. And I appreciate the clarification there on the immunizations. I think that has been very confusing for people this year. A large article in the paper today about it too. But just for simplicity's sake, can you just repeat that? As a public health entity, you're recommending that people do in fact get COVID vaccinations, and now is the best time to do that.
Correct. Yes.
And that can be done through the public health department, a pharmacy, a provider. It is currently available and covered by insurance, right?
Yes, that's correct. All good clarification. So insurance, because it's shared clinical decision making, insurance that is Affordable Care Act compliant must cover these vaccines. And then those who are eligible for VFA and VFC programs can come to us, can come to other VFC, VFA providers. There's been a lot of messaging that makes it seem like you have to make an appointment with your doctor and have a long discussion. That's not what shared clinical decision making is. A pharmacist, a nurse can complete shared clinical decision making. So you can walk into Walgreens, have a conversation about it. For a period of time, pharmacies were requiring a risk factor, and that's not the case anymore now that the ACIP recommendations have been approved. So it is very accessible. We've talked to lots of pharmacists who have said that their pharmacy changed away from the requirement of the risk factor right after the ACIP recommendations were approved. So yes, widely available. Insurance should cover it, and we recommend that everybody in all the age groups gets it regardless of risk conditions. The 2 to 17-year-old group without risk conditions would be a conversation about, but anyone who wants protection can access it and should.
Thank you.
Yeah.
And flu shots recommended as normal.
Correct.
And this is the best time of year to do that as well,
Correct.
right?
Before Halloween is the goal for flu shots, yes.
Getting mine tomorrow.
Yeah, great. Perfect timing.
Hi there. Again, thank you for your presentation, and thank you to your team. You guys do an amazing job. I know you've had a lot of challenges, through the federal changes, but our community is very grateful for what you do. You've mentioned in your presentation that you are scheduling community vaccination clinics. Do you have dates and locations for those yet, or will those be posted on the website? And then also what kind of vaccines will be available through those clinics?
Yes, great question. So with this kind of delayed start, we're actually still waiting on some guidance to complete our standing orders from guidance from the federal government. We should be probably booking our first clinic towards the end of October. We will do flu and COVID vaccines, and for eligibility criteria, it would be the same as our clinic. So folks would need to be eligible for VFC or VFA, and those will be throughout the community, churches, health fairs, that sort of thing. But yes, we'll carry flu, COVID for VFC, VFA clients, and we'll post them on the website once we get them scheduled. Yeah.
All right. No other questions? All right. Thanks, Molly. Appreciate that.
Thank you.
Yeah. Next, Caleb Cuttis.
Nobody has ever pronounced it right.
I didn't want to slaughter it.
Is it possible for me to see presenter mode?
I have not figured out how to do
Okay,
that with
don't
these
worry about it.
multiple
We'll be fine.
monitors. I'm working on it though. Okay. Sorry. Where is my? There it is. There you go.
All right. Well, thank you for the opportunity to present this morning. I'm Caleb Cuttis, the supervisor for our STI control and prevention section. I'm relatively new in this section, coming from emergency preparedness background. How do I go forward? Click. There we go. Quick overview of what my presentation will have in it. I'm going to give a quick overview of our section and what it's currently doing. We'll look at STI surveillance data for Douglas County, and then I'll give you some of our numbers that our outreach team has performed over the course of the year. We did have some new staff in 2025. I started as supervisor in June, so just close to 4 months. We also had a new secretary start in that month, Bianca Smith, who comes from a health informatics background, and we started a new disease investigator in September, Sarah E. Aries, who comes from Nebraska AIDS Project. We're now fully staffed with 2 secretaries, 4 disease investigators, 2 outreach staff, and 1 epidemiologist. We're very excited about that because we have been understaffed for most of the year. We do currently cover 4 surveillance conditions, kind of getting into the diseases that we perform surveillance, outreach, and all of our work for. First being chlamydia, also gonorrhea, syphilis, and HIV/AIDS. So before I talk about data, a couple of notes. For the most part, I'm going to be talking about data in rates per 100,000 population, so that when we're looking at race ethnicity data, it's a rate, not the raw numbers, so that we can kind of compare better between groups, right? Each condition that I talk about, for the most part, will start with an overview from 2010 to 2024, so you can see kind of the overarching trend. And then I'll show some data from September 24 to 25 with gender and race ethnicity breakdowns. Starting out with chlamydia, you can kind of see cases went way up during the pandemic in Douglas County. Nationwide and in Nebraska, they remained kind of flat, which is interesting, but our cases peaked in 2022, and we have been seeing a decline since then. Over the course of the last year, this is again from September 24 through this year, pretty consistently we see females with about twice the rate of males with chlamydia, and cases have remained relatively flat on a monthly basis. So we might be kind of going back to that trend of the mid-2010s where we had about 650,000 or 650 cases per 100,000 population per year. It seems like we're kind of stabilizing around that again. Looking at race ethnicity trends, you'll see kind of a pattern that holds for most of our STIs. Individuals who identify as other or multi-race carry the largest burden of cases by rate, followed by Black individuals. We do see high rates occasionally with Native American, Alaska Native population, but that is a very small population, so a very small number of cases leads to a relatively high rate, so just keep that in mind. Looking at gonorrhea, our cases were really high around 2020, and we've seen pretty sharp declines since then, and that mirrors national trends. CDC has reported nationally a pretty sharp decline in gonorrhea, and we have seen even, this is through 2024, but even coming into this year, we've seen a pretty significant decline in cases, which you can see kind of the trend when we look at the male-female data. Those numbers are trending down. Through this point last year, through the end of September, we had reported 1,000 cases of gonorrhea. This year, I think we have 643. So pretty significant decline. Hopefully that holds. Kind of interesting, conversely from chlamydia, we typically see higher gonorrhea rates among males, and that seems to be global as well. The race ethnicity data for gonorrhea, pretty similar to the chlamydia. Other multi-race has pretty high rates, followed by Black individuals. Same dynamic with the Native American, Alaska Native, where you see low number of cases and a low population leads to relatively high rate. Most of our disease investigator work right now goes towards syphilis. This is looking at cases of infectious syphilis, which is primary and secondary syphilis. That is syphilis cases that can be spread to other people. The U.S. has seen an overall rise in syphilis really since 2000. The CDC declared syphilis, I think, eliminated or released a plan to eliminate syphilis in 2000, and since then, due to a number of factors, including flat federal funding, syphilis cases have done nothing but rise, peaking during the pandemic, and Douglas County has experienced that as well. Our cases peaked in 2021. We had a high number also in 2024, but again, kind of following the trend of the other STIs, they do seem to be coming down in 2025. Through this point last year, we had reported, I can't see my notes, but it was over 70 cases, and I think this year we had about 58 through this point. There may be some lag in reporting, but that does appear to represent a decline, and you can kind of see a declining trend other than whatever we had going on in February, March among males. Overall, cases are higher in males than in females, but they have been declining over this year. Race ethnicity data is pretty similar to other STIs, where we see kind of higher rates among other multi-race individuals and Black individuals. That big spike in Native American, Alaska Native is kind of the same small population, small increase dynamic. We also track latent syphilis, which is syphilis that goes untreated past the point of having symptoms over the course or over a year. So these are individuals who test positive for syphilis, and we don't know when they were infected, but it was probably over a year ago. We don't generally consider that these people can spread it to others, but we do try and get them to treatment. We have seen a decreasing number of latent syphilis cases over the past year as well. And you can see pretty similar race ethnicity trends with latent syphilis, as would make sense. One thing that concerns our team greatly is the rise in congenital syphilis cases that we have seen in Douglas County. We actually had under 5 cases from 2010 through 2021. Since 2022, we have had 19 cases. And this represents, it's very concerning because it's a very serious condition for the infants involved. It can lead to miscarriage or stillbirth and all kinds of very serious birth defects. So we put a lot of work into trying to prevent congenital syphilis, as Molly alluded to. We work closely with our STI control clinic. We try really hard. We keep all of our pregnant individuals with syphilis cases open for as long as we can to try and get them the recommended treatment necessary to prevent congenital syphilis. And our disease investigators do significant outreach and follow-up throughout these cases. You can kind of see the number of investigations that we do opposed to the number of cases per year. 2024, we did 32 investigations for under 5 cases. So this represents a significant amount of work for our disease investigators, even if it doesn't end up being an actual case of congenital syphilis. They investigate every situation in which a mother does not receive adequate treatment that is documented prior to birth. HIV is the last condition that we work with in our office. Last year was actually the highest year for HIV cases in Douglas County since, I believe, 2017. We had 56 cases, and in Nebraska, it was the highest number of cases ever in 2024. We've seen a decline in HIV this year, which hopefully again holds. To this point last year, we had reported 40 cases, and this year we're at 28. That trend holds for AIDS as well. Looking at the breakdowns of that, these are not rates, these are just kind of raw breakdowns of the numbers. Following national trends, we see 81% of cases are male. The majority are either white or black, but again, white is by far the majority population of Douglas County, so that's a pretty low rate. 35% of cases among individuals who are black represents a higher rate. This point last year, we had 9 reported AIDS cases, and we have under 5 through September. So as far as AIDS, which is untreated HIV, kind of progressing to end-stage disease, we're seeing a decline in that, which is great to see. Moving on to our outreach team, by the numbers, they have attended 152 events in 2025, and at these events, they're doing education, offering outreach testing, doing all kinds of things. We have 2 outreach specialists in there doing about 17 events a month. We've distributed 214,527 condoms. They have reported reaching almost 6,000 people for STI education at these different events that they go to. We've had 170 people tested at outreach events and provided 357 at-home tests. So our 2 people are very, very busy at doing all that they do. That is my presentation. I'll take any questions that you have at this time. Yes.
Am I correct that for chlamydia and gonorrhea or Douglas County rates are still higher than the U.S.?
Yes, as far as I know, our rates have always been higher than the U.S. in chlamydia gonorrhea, which I think has to do partly with the fact that we just have high rates, and partly with the fact that the national average is all urban, rural, everything mixed together. So being an urban population that is kind of carries the burden for the state of Nebraska, so to speak, that has led to us having higher rates for a long time. For chlamydia gonorrhea, I do not. I can look into that though and see.
Having been on the board, this has been a situation for Douglas County as well as that in terms of chlamydia being higher.
Yeah.
Just trying to figure out what might be some of the underlying causes. So, anyway, I was just curious how we might compare to other urban areas our size.
That would be good to have. Maybe, the next time I present, I can certainly take a good look at that. I will say that is something that we're having conversations about, me and Leah, about how we can do more to address that. The main thing that we have going on right now is the burden of syphilis and HIV is so high that that's the majority of what our disease investigators work on, and they don't have the bandwidth to do a lot of chlamydia gonorrhea work, but we would very much like to decrease that number. So.
Well, I know you do good work, and thanks for all of that.
Thank you.
Yeah, go ahead.
Yes.
And I just have a question, and if you don't know the answer, it's just my curiosity. For congenital syphilis, if a baby's born, like the mother doesn't get the full treatment, a baby's born with syphilis, can it be treated after birth?
Yes.
Okay.
Yep. They, I can't remember the exact numbers on it. Been doing this for 3 months, but they do get IV bicillin that they're treated with, I think, for the course of a week or so.
Okay.
Yeah, they can be treated.
Okay,
Yes.
thank
So-
you.
Caleb, thanks for getting all these numbers put together. And it's great to see that in a lot of the cases that things are going in the right direction. Do you know if anything has changed in the last year on the way cases are reported or anything, either clinics or things that are less available that could have less or create less cases reported, or has it been consistent, do you know?
It's pretty consistent as far as I know. I'm not aware of any major changes in how STIs are reported, no.
Okay, that's
In
great.
fact, one of the things that we have been active in is advocating for more testing of pregnant women. It was LB 41 that we testified on, I think Leah testified on behalf of last year. So there's actually more testing going on, at least among pregnant women. So, you know, theoretically, you would expect to see somewhat of an increase with that, and we haven't, so.
Is there still STI testing available at the library on the Washington, on?
We do testing at the South Branch Library and the
Okay.
Benson Library, and I think there are others that they do one-offs at. I had it in my notes that I can't see, but yes, they do outreach testing at several libraries and
Okay.
Metro and UNO and lots of other places. So
Oh, Leah's coming up.
Helpful in the gap. At Washington Library, we have the vending machines, which have at-home tests in them. So we tried to kind of coordinate a little bit of that.
Leah will never miss an opportunity to talk about the vending machines.
All right, any other questions? Seeing none. Appreciate
Thank
it,
you.
Caleb. And then we have Dr. Jamin Johnson talking about the public health strategy innovation.
Good morning. I'll go fairly quickly to give just a brief overview of the division. I promise you that more depth is coming in the coming months. So next month you should hear from the one of the sections. I can't remember which, and I think in 2 months you'll hear from the communications section supervisor as well. So this will just be an overview of the division. Just as a reminder, these are the sections that make up the Division of Public Health Strategy, Innovation, and Planning. And these are all of the people who make the work happen. So I want to start by talking about public health communications. This is an area where we've seen quite a bit of growth and transition over the past several months within the division. Our communications team has been strengthening DCHD's media presence across multiple channels, and we've also increased our social media capacity. And I think that's been noted by our social media presence as well. These are just a couple of examples of some of the social media content and the communications content that did go out over the past several months. We also have improved the internal processes for handling public information requests. I will say that without Elizabeth's guidance, that would not have been possible, but we are very grateful for our partnership with the Douglas County Attorney's Office in being able to streamline the way in which we handle and respond to public information requests to make sure that we're meeting timelines, but that we're also providing information to the public as they request it and the information that they need. Some of the significant changes that we've seen within the section, the communication section, are, of course, the addition of a dedicated communications supervisor. And many of you have had the opportunity to meet PETA, but I wanted to take another opportunity to just note that we have dedicated leadership and supervision within that section now. She has continued to be assisted by Phil Rooney, and she's transitioned into a role where she is now our primary public information officer. We also want to note that we have experienced pretty significant transition in seeing Connie Blackburn retire, and those are shoes that are going to be extremely hard to fill, and we are definitely experiencing the loss of such a dedicated worker who has done pretty amazing work. You'll see it probably in everything you see. She was the person who polished everything that went out, and so her absence is definitely being felt throughout the department. We are poised to add an additional communications specialist to fill Connie's vacant spot, and that should be posted here shortly so that we can continue to expand and develop our communications capacity. I also want to note that we do still have a full-time information line coordinator that we have maintained the information line since the early days of COVID, and we've committed to continuing that as a vital opportunity for our community to access information and get in touch with us. Moving on to vital statistics. The vital statistics team continues to provide excellent service maintaining birth and death certificates for Douglas County residents. And we're currently collaborating with Douglas County Public Properties to build out a new home for the vital statistics team. We'll still be located here in this general vicinity, but instead of being in the Civic Center, we're moving just into the Hall of Justice. So we will just be on the opposite side of the cafeteria from where we currently sit. We also are continuing to navigate a heavy workload with the absence of a dedicated supervisor, and we're working diligently to try and get that supervisor position filled so that we can be at full capacity within the vital statistics section. Talking about our maternal and child health work, obviously you've heard us present on the work of FEMUR, I think 2 months ago, and that work continues. The reality is that as of about a month and a half ago, we had experienced 53 fetal and infant losses. That is sadly an underrepresentation of the actual number of fetal and infant losses. But I think it's important to highlight that that is a number that we should never forget, and it is a number that we can impact. I also want to point out that we are, through partnership and collaboration, continuing to expand our footprint and our presence in the space of both maternal and child health. We're partnering with the University of Nebraska Medical Center and Sherwood Foundation on and 4 other local health departments across the state on a cohort-based prenatal health program, I apologize. And we are also working in conjunction with Leah's division to leverage the chronic disease funds provided to us through the state to target maternal hypertension. We understand that maternal hypertension is not only a risk factor for the mother and birthing person, but is also a contributing factor in infant and fetal loss. And so we want to make sure that we are intentional about addressing and targeting that. Moving on to workforce development. So we continue to drive a culture of quality improvement and employee engagement through workforce development and quality improvement initiatives. And the 2025-2027 strategic plan is currently active with projects that strengthen leadership and process improvement and capacity across the department. And we'll also, I want to note that though we've seen a little bit of a dip in our staff retention numbers, that is a direct result of just some turnover in longstanding members of the workforce, and that we are actively working to fill all of those open positions. So we don't see that as anything significant or problematic. I could not be up here today without highlighting some pretty important collaborative work that we have done alongside this board. As many of you will remember, in 2020-ish, this board began the groundwork for what we initially were calling a legal epidemiology project, and that work led to a pretty expansive and systematic policy scan into identified priority areas, that being youth mental health and education. And though the work continues, there was definitely a capstone event last week when Jeannie Weiss and Blake Frederick were able to present alongside our partners from Change Lab Solutions. That's the contractor that we have engaged to support us in this work. We're able to present at the National Association of Local Boards of Health annual conference in Savannah, Georgia. And so that was amazing, and Jeannie's leadership was definitely on full display, and it was a great opportunity for us to demonstrate the work that is happening here locally to our national partners who are trying to replicate the work that we're doing. Talk a little bit about grants and projects that are happening. I'm going to start with tobacco and tobacco cessation. So we still continue to operate tobacco cessation efforts. We have a dedicated health educator who provides education and support for tobacco cessation information with the goal of expanding effective use of the quit line. In addition, as local health department, one of our responsibilities is to maintain compliance with the Clean Indoor Air Act. And so we continue to receive complaints of violators of the Clean Indoor Air Act, both in residential settings and commercial settings. And we have continued to provide guidance and support to those partners in our community who have received a complaint so that they can move back into compliance with that statute. Talking briefly now about the CDC Public Health Infrastructure Grant. This is a 5-year grant. We are wrapping up year 3 of this 5-year project, and we have reached 62% of our 5-year milestone. So we're on track as far as meeting our total objectives and milestones within this grant. Some of the key milestones that we had identified and the priorities that we'd focused on were around the creation and implementation of a revised strategic plan, attaining full Public Health Accreditation Board accreditation, and then building out and continuing our efforts to create comprehensive training plans throughout the department. I will say that we've seen areas where we can continue to improve. One of the areas really is around training and building out that comprehensive training plan. That's an area where we definitely can continue to strengthen and grow. I also have to note we've celebrated a few times, but we have accomplished some of our really large goals. We created and are currently implementing our strategic plan. We have adjusted our strategic plan from a 5-year plan down to a 3-year plan so that it's more nimble and actionable. And we also did successfully obtain Public Health Accreditation Board accreditation. That was a decades-long journey, so we're excited to have that one in the bag. And that doesn't mean that the work is done. That means we are now focused on remaining accredited. So moving on to performance management, we have long sought improvements in our performance management processes and the revitalization of a performance management system. And currently we have 15 active plans and 313 programmatic performance measures that have been identified and implemented in our agency-wide performance management plan. These measures, and I will note that what you're seeing displayed here is an illustration of one section's performance measures. So it's not necessarily a reflection of everything, but it gives a great opportunity to highlight how we are revamping the way in which we identify and visualize our performance management so that both internally at the staff level, everyone is aware of what those performance measures are and what action steps we have implemented to reach those objectives. And then it's a measure of transparency so that we can make sure that this is public facing and so that you all are aware of what these programmatic performance measures are and how they are identified as measures of success within our programs. One of the benefits is that we are able to build out individualized programmatic performance dashboards that do a better job of visualizing and telling the story related to our work and how that defines the success of our work. So having a performance management process is great, but having a structured and organized performance management system is what makes it effective in telling a compelling story. So we've been able to bring on a web-based system called Achieve It, which houses all of our agency-wide plans, so our strategic plan, our workforce development plan, all of those broad organization-wide plans, as well as our division and program-specific performance measures are all housed now within Achieve It. Can be updated very easily by anyone within our department. So performance measure reporting can be done through as simple as a staff member emailing their performance metrics directly into Achieve It, and it automatically updates in real time our performance measures so that we can make sure that we are keeping an accurate reflection of our movement towards our stated objectives. It also allows for us to embed these performance dashboards both in our intranet and broadly to visualize them on our intranet or put them out as a link for community partners to go ahead and access and see real time. I mentioned briefly our strategic plan, but I do want to note that we have currently implemented 5 projects for this year as part of the implementation of that strategic plan, and that we've seen around 27% of the total DCHD workforce actively engaged in moving those projects to successful completion. Our workforce development and quality improvement teams are also working with our management team and our senior management team to develop and implement these projects and to identify which projects will be implemented next year in our 2026 work plan. And we have roughly 15 identified projects scheduled to take place next year as well, driving us towards the continued implementation of our strategic plan. I've been highlighting monthly some updates as it relates to the implementation of our active strategic plan in my monthly board report, and I'll continue to do that. But I did want to honor the ask made by this board to specifically speak to the efforts around the implementation of our strategic plan today so that you could see it in real time. I will briefly talk about the Public Health Workforce Interests and Needs Survey, or what we affectionately refer to as PHWINS. We completed the 2024 PHWINS survey with an exceptionally high response rate of about 88% of our total workforce. That was a much higher response rate than I think we had anticipated, and we were grateful for it. We are currently in the process of developing a detailed report on the findings of the PHWINS survey so that it can be provided to the department staff and to you and our community in general. And we also want to note that what we've seen over time is that there's been a significant increase in overall organizational satisfaction between 2021's iteration of the survey and the 2024 survey. And we've also seen an increase in employee satisfaction as well. So those are 2 measures that we've identified as exciting, and we want to make sure that we are reflecting on them often. And we don't want this to just be something that we look at every 5 years when the PHWin survey comes out. But instead, we want to make sure that we're developing a broad longitudinal perspective on organizational satisfaction and the perceptions and the feelings of satisfaction within our workforce. And so as a result, we are launching a very brief pulse survey that will go out quarterly to the entire DCHD workforce. It should take no more than 5 minutes for people to fill this out. And this is then connected back to a couple of our sections' programmatic performance measures. So there's incentive for those programs to encourage the continued effective use of this survey as well, because it ties into their performance measures. But it also allows for us to ask similar or not just similar, but to ask the same questions that we've been asked from the National PHWin survey, to ask them internally so that we can continue to build some broad comparison data so we know effectively over time whether or not our workforce remains satisfied in their work, and if our organization continues to remain satisfied as well. So. As I briefly mentioned, some of the next steps are the rolling out of that pulse survey. We also will be providing a very detailed report on the PHWin's findings to our internal workforce and then to this board, and putting it out publicly for the community to see, and making sure that the published PHWin's report is that we can explain what those findings are. We want to make sure that we can explain what the entities that conducted this survey found, and how that is replicable to our agency and why it's important. And then we're going to continue to target initiatives that drive workforce satisfaction and support our workforce as a direct result of the things that we find through our quarterly pulse surveys. All right. So that's in a nutshell. That I know is a lot.
Questions for anybody? Anybody? Jane?
I just wanted to make some comments about the NALBA conference that we went to last week. As we sat through sessions and listened to other health departments throughout the country, my takeaway was, despite a lot of the changes that are happening in the current landscape, we are weathering the storm very well compared to our counterparts in other communities. And it just made me very proud, and definitely is evidence that we are doing something right here in Douglas County. So I want to give kudos to the entire team that you guys are pulling together, making this happen, and we are keeping public health on track in our community. So congratulations. It was very eye-opening to be able to compare us to other communities nationally. So obviously my perspective is only here in Omaha, Nebraska, and Douglas County. To see that was just amazing. So huge shout out to the team.
Thank you.
Nice. Well, thanks, Jamin.
Yeah, thank you. I do want to note that relative to the legal epidemiology / policy scan project, because one of the stated objectives was to build internal capacity so that we could continue that work in perpetuity. We have intentionally identified the need to leverage this capacity to expand the work that we're doing around infant mortality. So we are intentionally shifting that capacity into our FEMR space so that we can leverage the ability to conduct comprehensive policy scans and provide public health policy recommendations as it relates to what we know is a very real problem of babies not making it to their first birthday. So.
All right. Thanks. The next, we have the director's report.
morning. All right. Well, to start with, I have a celebration of one of our employees and their years of service with us. So we are very, very happy to honor Anita Jones Whitney, who is one of our lead risk assessors in our environmental health division. She has been with us for 15 years now, so we are just extremely grateful for her hard work, for the absolute commitment to the families that she serves, and for the smile on her face every single time I see her, which just always brightens up the day. And so we are just so very grateful to have her continue with us, and hopefully she'll give us 15 more. All right. We do have her chief here today. Eric, do you have anything that you want to say? Are you good? I'm good. He's a man of few words. Yes, so come on up. So we're going to smile for Damon. And then I'm going to give you the rest of this. So thank you. Yes. Also, thank you for sitting through the whole meeting for that. Typically, we try to do those toward the front, but today it worked out a little bit differently. But thank you again just for all of your hard work and just for being the wonderful team player and bright spot in our department. Yeah, you got it. Sorry about that. All right, I have a few updates for you. First of all, I wanted to give you a quick update on the foundation that we've been working on. We were able to get permission from the Douglas County Health Center to use the name that we had chosen, which was really close to the name that they already use. And so we were able to secure permission to use the name we wanted, which is simply the Douglas County Health Department Foundation. Very, very simple, easy to remember, hopefully. We got that paperwork signed off back to our attorneys, and now they are working on completing the paperwork that will go to the state for the state's part of that process. And then from there, we will have our first board meeting most likely. I do have commitments from 2 members. I have one more that I have a meeting on the schedule. It's just a ways out. And so we're waiting to complete that and see if this person will be interested in being a founding member on that board and be moving forward from there. So I would anticipate that our first board meeting will occur sometime early in 2026, likely in January, perhaps February, but hopefully January. You may be wondering why we had community benefit presentations. We had one and then we don't have any more for a little while. And really this is just us trying to better align when we're asking that from organizations based on when their reports are due internally, so that we're not asking for that as they're trying to scramble to get things done and into their own boards. So we're starting that back up in January, no fear. We will still be doing those community benefit presentations. We just want to make sure that we're doing a better job of syncing our cycle with theirs. So more to come there. We are in the process of completing some community health improvement plan community conversations. I was able to complete the very first one of these just this past Saturday. This one was kind of a closed community session, if you will, at the Empowerment Network, which is a convening of a whole lot of different partners that serve the North Omaha community. And so we had quite a large showing there, and we're able to get some wonderful feedback and some good ideas from that group. And so that one is in the books. We also have a Facebook Live that is coming up that we are hosting on the Douglas County Health Department Facebook page next Wednesday, October 22nd at 6:30 p.m. And we will basically be presenting the same data and having the same conversations just in a Facebook Live conversation format, and we invite everybody who is interested in providing feedback to attend that and provide us some feedback. There will also be a link to a survey if that is a more comfortable way for people to complete that. We definitely encourage anyone and everyone to attend that if they're able to, since it's online and they don't have to even get out of their pajama pants if they don't want to. We also have one coming up in Midtown, the Neighborhood Association meeting will be hosting me to kind of have another somewhat closed community listening session with that group, since it's a gathering of many of our heads of neighborhood associations around the community. Looking forward to that. And then we have another one that will be happening in South Omaha, and I do not have the date on that one with me, so I will get that out to you guys so that if you are interested in attending any of those, please feel free. I'm pretty sure no one is going to say no to a board member coming in for that. I was going to give a quick correction to Leah's division report, but Molly took care of it, so I don't have to worry about that. So thank you, Molly. Simply, in the report that she submitted last week, we still had not received COVID vaccine for VFC, VFA, and we did get that yesterday. And so I just wanted to make sure that we clarified that we do, if you had read that report and thought we didn't have it yet, we do, in fact, we just got it. We also did hear that DHHS says that the supply that we will have this year for VFC and VFA is going to be somewhat limited. So we'll see what that means. We don't really know yet. Our plan is just to give it until we don't have any more to give and can't get any more. So that's what we're going to be doing. Our WIC clinic that was located in the Center Mall was able to successfully move on September 26th to 88th and Frederick, so new location for them. This was long overdue for them. We did have some environmental challenges for them that they were experiencing pretty frequently in that particular building, and so we believe that this will be this new location will be better for our staff and also will be better for our clientele that are coming in. And so we're really excited they were able to get that move completed. Just a few highlights from other reports. Environmental Health is getting ready to field test their food inspection software. So we've been working for, I think, a little over a year now to get that more electronic format for being able to complete those inspections up and running. It's going to mean efficiencies for our staff, which is wonderful. And I think it will also make communication with our food vendors a lot easier and more in the moment, if you will. And so we're going to be field testing that here in just the next month or two. We also have new ordinances that are ready or close to ready to go to City Council. One of those is around pools, an update to the pool ordinance, and then we also have an update to our livestock ordinance that's coming. And our environmental health teams have been really busy meeting with different groups in the community ahead of those ordinances rolling out so that we can assure that everyone is aware of what's coming, is on board, similar to what we just did with our food or the changes to Chapter 11, the food ordinance. So they've been very busy trying to get all of our ordinances updated, and I think you'll also see a lead one maybe in the next year or so. A couple of updates from our EPI preparedness sections. We just wanted to remind people that flu is indeed circulating. We have had a handful of positive flu cases out there. Still, the levels across Nebraska at this point are minimal, but they're definitely happening. So we do recommend that people get out there and get those flu shots. COVID also continues to circulate. Somewhat low levels there, certainly not like some of past years that we've seen, but it is still out there, and we do certainly encourage people to get that COVID shot as well, since it is available and insurance is continuing to cover that. I won't go too much into the ACIP recommendations because Molly did a great job of covering that, but do let us know if you have any questions around that or need further clarification. We do anticipate that probably sometime in the next few months, 6 months or so, they'll probably be looking at the rest of the childhood vaccine schedule. So there could be more conversation that needs to happen in this format just to make clarifications in the future. In terms of legislation, even though the legislative session is not currently happening, that will start in the beginning of January. Certainly there is a lot happening right now legislatively with some interim studies and things like that that are happening. I did want to update you that NALED, the Nebraska Association of Local Health Directors, is hoping to have a community health worker certification legislation introduced this session. So I get to have the pleasure of being part of the core legislative team for NALED. And this, really what this legislation will accomplish is providing a standard for the certification of community health workers, assuring that programs that educate our community health workers are meeting standards across the board and have that certification. Lots of great reasons for this to happen. One of them is that it elevates the profession and establishes community health worker work as a profession in its own right, which we think is extremely important. We have a lot of community health workers who this is exactly what they want to be doing. They love it. They're fantastic at it. And they need to have really that standardization to prove that this is a profession in their own right. And so we're excited about that. It also sets up medical clinics, organizations that provide clinical services that also utilize community health workers in those settings to, at some point in the future, be able to bill for community health worker time. So this speaks to the importance of sustainability and funding for these types of positions. That's something that's going to be enabled. The very first step that has to happen, though, is that we have to have that certification and that standardization. So we're working on that, and we're very excited. We've had conversations with Senator Hardin, who's the HHS chair, and right now we're doing some gathering of background information for him, providing talking points. He's doing his own research, but the hope is that we'll be able to get something introduced this year and hopefully passed. There are also a lot of other interim studies out there. One of great interest comes from Senator Riepe, who is one of our Omaha senators, and it's an interim study looking at rural medical care and how to essentially attract and retain medical personnel, physicians, providers, nurses, doctors, in rural settings. And so that is something that is coming up. We should have more on that in not too long. And I also have multiple meetings with senators that are set up in the next 6 weeks or so. So getting to just continue to build and strengthen those relationships, especially as we're moving into the legislative session. Certainly funding is something that we're really keeping a close eye on. And of course, we won't know about any changes to state funding to public health probably until sometime during the legislative session, but we will certainly keep you updated on that as we know more. And with that, I think that is all I have for you, but I am very happy to take any questions you might have.
Jeannie?
I just wanted, you had mentioned the VFC and VFA schedule, and you're going to get a limited number. What is that calendar year for them? Does it follow the state fiscal calendar, or is it calendar year?
That's a great question. Molly, do you have that answer?
And what Dr. Hughes was referring to specifically was our COVID allocations for VFC and VFA are really low. So there's a cap for this season for COVID.
Okay.
And we don't really know how much we'll be able to get, but we know it's maybe even half of what we got last year, which is kind of unprecedented for VFC because that program, we're supposed to be able to get everything on the ACIP list, and COVID is still on the ACIP list, so it's a little confusing how that came to be. But
thank you.
Yeah, and they seem to be treating COVID season kind of the same as with respiratory season. So, thinking about flu and RSV and all of those things that are circulating as well.
Thank you, and thanks for those updates. Another item that's been in the news recently is the rollout of medical marijuana regulations at the state level, which has not entirely been smooth, and I think may get challenged yet, but they were required to issue those in October and make them final sometime soon. And we've made preparations at the city level for that too, in terms of our zoning code and allowing those things to be legal and regulated. Is there a role for the public health department in that as that continues to roll out, or in guidance to providers, or have you had any involvement with that so far?
We had some low-level involvement when the commission first started their work. The first iteration of the bill that came out actually had public health departments written in as essentially certifiers of establishments selling and anyone growing medical marijuana. However, we kind of checked around the country to see what's the normal, what's the usual for a health department's involvement. And typically at the local level, health departments aren't really involved in that process. They did end up taking that language out. So at this point, we don't have necessarily any role, at least from a state statute standpoint or from the commission's standpoint in terms of us needing to inspect or approve anything. Of course, at the city level, if there are ordinance changes that would include the health department, that's a conversation we certainly could have. I will say that the capacity that we have to take on something like that is pretty low at this point, as our environmental health section is pretty understaffed. So if we were to take something like that on, we would have to first of all figure out what it meant, what exactly we would be inspecting or approving, but also we would need some sort of support to hire more employees to actually complete that work, because we simply wouldn't be able to take on that capacity at this time.
Okay, thanks.
Any other questions? All right.
Thank you.
Was there any questions on the department reports that were submitted? All right. Seeing none. So our next Board of Health meeting is November 19th. We have committee meetings on Monday, the 28th this month via Zoom if needed. Can I get a motion to adjourn the meeting?
Sorry. Wade? Yes. McNally? King? Festerson? Yes. Jones? Rogers? Espinoza? Wilkin? Yes. Weiss?